This program is brought to you by Emory University.
Our presenter this morning is Ahmed AlBadri. Ahmed is one of our third-year fellows in the clinical investigator tract. He is from Lebanon, if I'm not mistaken. No, Baghdad, sorry, that's right. But you went to medical school in Lebanon. Sorry. Went to medical school in Lebanon, came to the United States, did his residency at Lenox Hill in New York, if I'm not mistaken, then did a research fellowship in Los Angeles at Cedars-Sinai, where he met Dr. Mehta. And then came here for fellowship. And he is a budding young interventional cardiologist, and he's going to talk today about MINOCA, which I presume is myocardial infarction with non-obstructive coronary arteries. Oh, good. I got that. Okay. All right. So Dr. Ahmed AlBadri.
Thank you, Dr. Williams. I'm going to talk today about MINOCA, which is myocardial infarction with no obstructive coronary disease. I have nothing to disclose. I'm going to start with a case. This is a 60-year-old female with exertional angina that gets better with sublingual nitroglycerin. Past medical history include multiple presentations to the emergency room for chest pain. History of anstomy with a peak troponin in outside hospitals of 1.2 with a previous angiogram that showed non-obstructive coronary disease. However, it was reported luminal irregularities of the RCA. She was placed on medications, aspirin, isosorbate mononitrate, and sublingual nitroglycerin, and the echocardiography showed normal ejection fraction and normal wall motion. So patient presented, this was her EKG in the clinic, and it just showed sinusoidem with subtle findings, which may be suggestive of right coronary artery disease. At this time, you're thinking about what is the differential diagnosis for this patient. Is it epicardial coronary vasospasm, since she had an infarction, however, with elevation of the troponin, however, no obstructive coronary disease? Is it a plaque rupture? Is it coronary microvascular dysfunction? Or is it spontaneous coronary artery dissection? And I think these all are valid kind of in the differential diagnosis. And that's what we call it MINOCA now. And then we'll go through all these things. Now, some of the people, they might think, is it Takotsubo cardiomyopathy? Is it myocarditis? And I think they are both also a valid in the differential diagnosis. However, they are not included to be as MINOCA. And now, the fancy name for it, they call it troponin elevation with no obstructive coronary disease. We'll go through why there is a difference between the two. This patient kept having chest pain, so she was referred initially to cardiac MRI to investigate whether she does have myocarditis or some other etiology. And it showed here subendocardial to transmural late gadolinium enhancement consistent with the focal scar involving the mid-anterior septal area. She was placed on Coreg as a treatment for anstomy. Then the patient kept having chest pain, so she was referred again to another Cath. That was about a year since her initial presentation. And you can see this is her baseline coronary angiogram. So I'm going to just point out here. And you can see there's little small vessels, however, they're patent, they're open. Giving the patient a high dose of acetylcholine to test for a spasm, you can see that the LAD almost occluded. There is a very small, tiny vessel that responded pretty well when we gave intracoronary nitroglycerin, 200 mics. Now it's very open and wide. That's, you come up with a diagnosis of this is coronary vasospasm. So the patient was diagnosed with MINOCA with a myocardial scar on MRI, suggestive of previous myocardial infarction. She had coronary epicardial vasospasm. Patient was placed on losartan, pravastatin, cardizem for spasm. Isosorbate minor nitrate and aspirin continued. Carvedilol stopped because it can trigger spasm in these patients. And she was referred to cardiac rehab. During follow-up, the SAC score in her case was 67. 1 year follow-up went to 33. The higher SAC score denotes a better quality of life. And of course, you didn't have any further hospitalization for angina after that. Before the third universal definition of the myocardial infarction, there was no mentioning about myocardial infarction with no obstructive coronary disease. In the third, there was a small section about MINOCA, and then I think on the fourth universal definition, there is a big section about MINOCA. So it started to be more recognized in the literature. The terminology is MINOCA. I think it's very easy to say, especially when searching for literature. It's very easy to type in PubMed or Google MINOCA, and it will list a lot of these publications. Estimated incidence of 50 to 150,000 cases per year in the United States, and these are data coming from registries. This is a busy slide and shows the recent published AHA diagnostic criteria for MINOCA that was published in April 2019. But we'll make it simple. I think to have a diagnosis of MINOCA, patient has to have three main criteria. First is the patient has to have acute myocardial infarction as per the fourth definition of myocardial infarction. And that means detection of rise or fall in cardiac troponin with at least one value above the 99th percentile upper reference limit, plus one of the following: either symptoms of myocardial ischemia, new ischemic changes, imaging evidence of new or loss of viable myocardium or new regional wall motion abnormality, and also identification of coronary thrombus by angiography. The second criteria is non-obstructive coronary disease, and that's defined as having less than 50% narrowing in the epicardial vessels. And third criteria is no specific alternate diagnosis suggesting of increase in cardiac troponin, and that's excluding sepsis, pulmonary embolism, and of course myocarditis. And the reason myocarditis and Takotsubo, myocarditis is it's an inflammation of the myocardium, and it's not involved the epicardial vessels. That's why it is a different entity and shouldn't be included in the MINOCA. The same thing, Takotsubo, the etiology is very, we don't know really much about what's causing Takotsubo as of now, but at least we know that probably it's not an epicardial coronary artery issue. What types of patients get MINOCA? Non-obstructive coronary disease seen in all forms of acute coronary syndrome, particularly among women. And this is from the registry. So women who presented with MINOCA and STEMI, the prevalence is about 4 to 10%, compared to men, which is between 2% to 8%. Women who presented with STEMI and found to have MINOCA, they range between 9% to 15%, versus men is 4 to 5%. MINOCA is more common among certain racial and ethnic minorities. It's more prevalent in Black African American and Native American, and also Hispanic population. MINOCA patients are often young. They usually, about a quarter of them, their age is less than 50 years old. However, about 27 were aged over 70. So it can affect all the age groups. However, it's more common in young. Conventional risk factors are common among patients with MINOCA, and this is from the Virgo registry. They included small number of patients, 224, with MINOCA age less than 55 years old. 21% of those, they have diabetes, 60% they have hypertension, 54 they have dyslipidemia, 38 they have smoking history, and 94 had at least one risk factor. What is the prognosis after MINOCA? And this graph coming from different studies. The first one is the ACTION registry that included in the in-hospital mortality, and shows patient with MINOCA, they have about 1.1% mortality. The meta-analysis that was done looked at 1 year mortality, showed 4.7%. And then the longest follow-up is the Sweetheart. They have data about for median of 4 years, and shows about 13.4% mortality. And this is compared to patients, the general population who are age and sex matched, which they have 5.7 out of the hospital mortality at 4 years. There's also some studies that looked at the major adverse cardiovascular events over long-term follow-up for MINOCA. And the two major studies is the Sweetheart registry, again, that looked at the 4 years follow-up, and also the Cath PCI registry that looked at people with MINOCA at age more than 65. It's a Medicare registry. And as I said, the death was 13.4% in over 4 years in Sweetheart, compared to 12.3% at 1 year in Cath PCI registry. Also, the recurrent MI is 7.1 versus 1.3 in Cath PCI registry. And overall MACE, if you look at the bottom, is about 24% at 4 years MACE. That include either death, recurrent MI, or heart failure hospitalization, and 18% at 1 year. So it's not really a benign condition. And actually there's more studies that looked at comparing MINOCA patients compared to patients who have no coronary vascular disease versus patients with obstructive coronary disease. And you can see here, it's in the middle. These patients, they do actually better than patients they don't have any disease. However, they do worse than patients they have myocardial infarction with obstructive coronary disease. This is a very interesting study that it's from the Korean Acute Myocardial Infarction Registry that looked at 8,500 consecutive acute MI patients, and they grouped the cohort into three groups. Group 1 are MINOCA patients. Group 2, patients who have 1 or 2 vessel disease. And Group 3, they have left main coronary disease and triple vessel disease. And you can see there's no difference actually between MINOCA population and patients with 1 or 2 vessel disease. However, definitely there is a significant difference with those who have left main coronary disease and triple vessel disease, because these patients, they tend to be more sicker. Reinfarction after MINOCA. Are these MINOCA again, or is there another etiology? And this is the data coming again from the Sweetheart registry, identified 570 MINOCA patients with recurrent MI. And half of them, they get recathed. And I think the reason why is that some of these patients, we think we know what's going on with them, and we always say that they have MINOCA. But interestingly, half of them, they progress to obstructive coronary disease. And maybe just because during MINOCA, they might have a small plaque rupture, and that can progress over time and causing more obstructive coronary disease. So probably attention needs to be, more attention needs to give to these patients when they represent again. There's different flavors and etiologies for MINOCA that include plaque rupture, vasospasm, dissection, thromboembolism, coronary microvascular dysfunction. These are the main ones that can cause MINOCA. I included myocarditis and Takotsubo, however, they are not part of MINOCA. They are not involved in the coronary vasculature trees, the etiology pretty much. Therefore, I'm going to just put them there just to kind of differentiate the two. And I think Forrest Gump's mom got that decades ago when she said life is like a box of chocolate. You never know what you're going to get. And I think what she meant is actually MINOCA is like a box of chocolate. You never know what you're going to get. And the reason why I'm saying that, when you open a box of chocolate, it looks the same to you, but then you have to take a bite and get in and see what you're getting yourself into. Because the coronary arteries on angiogram, sometimes they look fine, but then once you do more advanced intracoronary imaging, you will see something different. So let's talk a little bit about the plaque rupture or erosion. There's a limitation for coronary angiogram, and this kind of picture showed that. On the left, this is an angiogram that looks completely normal. However, two sites in the LAD showing by IVUS Here, this is represent the distal part, and this arrow represent the proximal part. And then you can see on the distal side, there's a little disease, but more proximal. This is a little bit just, maybe a little bit of a atheroma. However, the distal part looks on angiogram just fine, but it has a large concentric atheroma, sorry. The lumen size of both sides is similar because of the remodeling. Not all plaque rupture is evident on angiography. If there is a plaque rupture that it's probably causing thrombosis that's occluding more than 50% of the coronary artery lumen, then it will be evident on the angiography. However, if there is a small thrombus that's accumulating in the lumen, the problem is not going to be evident on the angiography, and that's the tricky part. And that's what we tend to miss in these cases. How frequent is plaque rupture? There are three main studies that looked at it, and again, they are very small studies. One study, it's a prospective study, 50 women, IVUS that was done of 2 vessels at least, with a median of 2 days after the indexed myocardial infarction. And 38% had a plaque rupture. In French studies, 68 women and men, they underwent IVUS, and that was within 24 hours after myocardial infarction, and it was found they have 27% had a plaque rupture. And these all included MINOCA patients, of course. Another Polish study is 38 men and women. They used OCT, which is a better modality for intracoronary imaging, with a median of 11 hours after the myocardial infarction. And this study, they showed a 29% plaque rupture, erosion with thrombus, or calcified nodule. And it seems to be the plaque rupture correlate with the non-obstructive coronary disease burden. So people who have between 30 to 50%, they tend to have more plaque rupture. And that's kind of like more intuitive. However, plaque rupture ulceration located in a normal area, totally normal of the vessels in about half of the cases. Our plaque rupture, ruptured plaques in MINOCA similar to the plaque ruptured in myocardial infarction with obstructive coronary disease. So we think these are soft plaque that's usually seen in obstructive coronary disease. They usually remodeled outwardly. However, this study, they looked at this, and then in fact, patients with MINOCA, they present with about half of them with a fibrous plaque, 32% with mixed fibrofatty, and 16% with a mixed fibrocalcific. And actually, they're not outwardly remodeled. So there's something specific about these plaques that happen in MINOCA patients. Plaque erosion, it's a different underlying plaque morphology. They tend to have more smooth muscles and proteoglycan, non-necrotic core. Not seen on IVUS studies, however seen in some of the OCT studies. Common cause of ACS based on OCT study, and there's no sex difference. More common among younger women in autopsy studies of sudden death victims. So now the question is, if the thrombus is not occlusive, what causing the myocardial necrosis in the setting of plaque rupture or erosion? Is it a spasm? Is it transient thrombosis with spontaneous thrombolysis? Is it embolization of atherothrombotic debris? I'm going to talk a little bit about another case. This is a 65-year-old female, history of hypertension and hyperlipidemia, exertional angina, and abnormal stress echo. She had a Cath and showed no obstructive coronary disease. This patient underwent a diagnostic angiogram, and you can see the LAD looks fine. It's open. Yes, there is some luminar irregularities. But then with the coronary functional testing, infusion of acetylcholine, at the lower dose, it shows a significant spasm, and that's resolved with nitroglycerin. And that's kind of like the diagnosis of a vasospasm, and we'll talk a little bit about that. It's hard sometimes to identify coronary vasospasm unless you do more kind of comprehensive testing. However, sometimes we can see spontaneous spasm during Cath, and that sometimes it's helpful. provocative test, or what we call it now here at Emory, the functional testing, not routinely done at the time of acute infarct. 3 recent studies using a provocative test showed a 24 to 58% induced spasm in MINOCA patients. Among those with a spasm, about half of them, they tend to have epicardial spasm, and the other half, they have microvascular spasm. Most with spasm also had some non-obstructive coronary disease. So it's kind of like sometimes in MINOCA, they have more than one etiology causing their MINOCA or the myocardial infarction. A treatment is very easy, is calcium channel blocker or nitrate. So these patients, to identify them, sometimes it's very easy to treat them. Predictors of coronary spasm, these patients that tend to be younger, male patients, present with typical angina and more presentation of ST elevation rather than STEMI. However, in this study, history of hypertension, diabetes, hyperlipidemia, family history of coronary disease, smoking, and peak troponin was not associated with the spasm. As I said earlier, MINOCA can be multifactorial. This is a study that looked at spasm patients, 12 patients with myocardial infarction or out of the hospital cardiac arrest, had OCT at the site of the spasm. And you can see 12.5% they had a plaque rupture at the spasm site. 25% they had plaque erosion at the spasm site. 56% they have luminal irregularities without thrombus, and 6% there's none of these findings. Another case is a 36-year-old female presented with a new onset peripartum cardiomyopathy. On EKG showed anterior infarct, as shown here. So this is her angiogram. You can appreciate there is a left main dissection right here. And sometimes this gets missed on angiogram unless you go thoroughly through the angiogram. So at that time, patient was just treated conservatively, and she did fine. However, 2 days after that, she back in the Cath lab in cardiogenic shock. Impella was placed at that time. The circ, it's a little bit open, it was stented, and then was unable to wire the LAD and unable to stent it. She went back to the CCU, and she did better over time. The impella was out, and she recovered. This is Dr. Jabber, if you can recognize this Sule. 4 years after, she presented again with chest pain while she was skiing. She had positive troponin, and you can see amazingly how the LAD recovered, circ recovered. She did fine. But then, now she has the RCA that showed again another SCAD. So it's really unpredicted how these patients do with the SCAD, whether to treat them conservatively, be more aggressive. And unfortunately, we do sometimes see a lot of patients, they die because of this. So we'll talk a little bit about disease, and I'm not gonna go through this a lot. I think Andrew McHugh last year or the year before, he gave an amazing talk about SCAD. So I'm gonna just briefly talk about it. So by definition, it's non-traumatic, non-iatrogenic, non-atherosclerotic separation of the coronary arterial wall by intramural hemorrhage, creating a false lumen with or without intimal tear. Separation can occur between any arterial layers, whether the intima, the media, or the adventitia. Resulting intramural hematoma compresses the arterial lumen, compromising the antegrade blood flow, and can cause myocardial ischemia or infarction. Coronary dissection is a cause of MINOCA, but most dissection is not MINOCA. And the reason I'm saying that is just by definition, to have a MINOCA, you have to have less than 50% narrowing of the coronary lumen. And some of the SCAD cases, they have more than that, and more than 50% narrowing. So here you can see this is type 2, which is the long dissection, and then there is a narrowing more than 50%, versus this is the type 3, where they have very small tubular that's usually about 2 centimeter in length, and that's what's considered to be as part of MINOCA. And of course, there's no plaque or anything inside the lumen, and this is kind of the area where the hematoma is. It's outside the lumen. Now we're collecting more, and we see more studies about SCAD. It's first reported in 1931. It's underdiagnosed, poorly misunderstood. It's reported between 0.2 to 4% of acute coronary syndrome angiograms, and that depends on the studies. The largest one is the CAN-SCAD study. The last one that's included 750 patients, and that's when reported 4.5%. These are the types of SCAD. The type 1 has a classic appearance of contrast dye staining of the arterial wall with multiple radiolucent lumen. Type 2 is usually long, diffuse, typically more than 2 centimeters, with a smooth narrowing that varies in severity. And type 3, these are the MINOCA patient type 3. They actually have a focal or tubular stenosis that mimics atherosclerosis, typically requiring intracoronary imaging to prove the presence of hematoma or double lumen. Let's talk a little bit briefly about thromboembolism. This is a little bit of a busy slide. Factor V Leiden activated protein C resistance was found in 9 to 15% of young MINOCA patients, compared to 3 to 5% of age and sex match in myocardial infarction with obstructive coronary patients. Up to 24% of MINOCA patients may have an inherited thrombophilia, like a factor V Leiden, protein C or S deficiency, antiphospholipid antibodies, similar to the cryptogenic stroke. When antiphospholipid antibodies present in MI patients, about 20% of them have MINOCA. Also, there is an evidence that exogenous hormone use can play a role in thrombosis as well. How about microvascular dysfunction? We'll talk very briefly about this. The microcirculation, it consists about 70 to 90% of, it consists of the resistance in the coronary circulation. Overall, the coronary circulation consists of the microcirculation, which is the epicardial vessels that we see on angiogram, and then it consists of the microcirculation that we don't see on the angiogram, and sometimes we test it indirectly. The microcirculation, it is responsible for regulation of blood flow, and also the exchange of metabolites and nutrients. We looked at the prognosis of patients with microvascular dysfunction from WISE study, and you can see women with non-obstructive coronary disease, they have abnormal CFR. Actually, they have increase in mortality and also MACE, and that's include myocardial infarction, cardiovascular death, heart failure, and also stroke. When we looked at the coronary blood flow, which is basically representative of the endothelial-dependent microvascular function, it was not significant. However, after adjusting for age, history of hypertension, dyslipidemia, smoking status, diabetes, then there was a significant difference. Each 10% reduction in coronary blood flow, there was a 12% significant increase in risk of all-cause mortality with a hazard ratio of 1.12, with also increase in increase in 4-component MACE with 1.1 hazard ratio. And why that happened? There's a theory that maybe because of the when there's a small plaque rupture in the epicardium, this will send some plaque debris, platelets, neutrophils, trigger inflammation that goes showered to the microcirculation, obstruct the microcirculation, and that will trigger a different cascade that can cause an infarction. And this coming from various studies, but the largest one is 50 women who had a STEMI that they underwent IVUS in 2 vessels. And you look at here, there is these are proven to have a small plaque. However, it's not ruptured. Yet on an angiogram at the same territory, there is the transluminal late gadolinium enhancement that's suggestive of an infarction. There's another entity now, there's a lot of interest is the microvascular spasm, and why that happened is usually either because of impaired vasodilatation in the microvasculature or increased vasoconstriction in response to a lot of enzymes and metabolites, and also some physical factors. How can you make the etiological diagnosis? And this is the main thing, is this came out in April 2019, that it's an AHA scientific statement about the contemporary diagnosis and management of patients with MINOCA. It's a working diagnosis. You cannot make a diagnosis just by saying this patient has this or this patient has that. I think it needs more working. And this is what's the traffic lights approach that was proposed in that statement. And then we can go through this. First, the initial step is to kind of diagnose the acute myocardial infarction, which is the rise and fall of cardiac troponin with one level above the 99th percentile, plus ischemic signs and symptoms. Also, on angiography, by definition, they should have no obstructive coronary disease. Now, can you rule out other clinical contests like sepsis, pulmonary embolism, cardiac contusion, or any other non-cardiac troponin? If not, then it is, as I said, is a working diagnosis. Now, go back and review the angiogram, or if it's an angiogram from a different hospital. Did you miss a small vessel obstructive coronary disease? Did you miss coronary emboli, thrombus? Did we miss a SCAD patients? And usually these get missed easily. If not, then consider doing LV function assessment, whether by echo or LV-gram, to rule out Takotsubo syndrome or other cardiomyopathies. The other consideration is to do cardiac MRI, and it's very helpful to rule out myocarditis. Now, if none of this helpful, then you can move to the green that now you have a MINOCA and it's a coronary, pretty much coronary etiology. Now consider to do coronary vascular imaging, IVUS or OCT. You're going to diagnose plaque disruption, coronary embolism, or SCAD. And sometimes if you want to work up for spasm, then to consider doing coronary functional assessment. And sometimes, as always confusing in these statements that usually depends on small study, is you don't get any diagnosis for MINOCA. So the step one, what could we have missed? Again, to review the angiogram. This is a 57-year-old woman, traveling artist, no coronary disease, intermittent chest pain. She had a recent breakup, so you might think that she maybe had Takotsubo cardiomyopathy. Recurrent chest pain on exertion. She had ST elevation in V3 to V5 with a troponin of 29. It's pretty significant. She had a catheterization in an outside hospital, and she's been told there's no blockages. She was placed on dual antiplatelet therapy, statins, and Xanax because she was always anxious, and continued to have this chest pain. So at least you see that someone thought about this as an infarction because of an increase of troponin, and even though there's no blockages, they put her on dual antiplatelet therapy. They put her on statin as a treatment for myocardial infarction. But what if this patient had other etiologies as part of MINOCA? And we'll look at this. This is just reviewing the Cath from the outside hospital. And you can see there is a nice CAD. However, it was missed maybe in that view. These are like the different view. Yes, you cannot see it in this view. Maybe here you start seeing something in the LAD. And then here it's very obvious. And this is a SCAD patient that is easy to treat in this situation. It might be, it's a different approach from what was the patient placed on in terms of medications. Now you found there's no apparent cause of angiography. So would you pray for the patient and send them on dual antiplatelet therapy, statins, ACE inhibitors, and try to control their symptoms? Or would you be more a little bit aggressive, maybe putting a wire, trying to do more imaging studies to identify really what's specifically causing their myocardial infarction with no obstructive coronary disease? If you cannot see any apparent cause, then consider to do a little bit more and specifically intracoronary imaging. Here at Emory, we do that, I think, a lot, relatively. And should intracoronary imaging be routine in MINOCA? The AHA scientific statement, they say, given the frequent presence of plaque disruption in patients with MINOCA undergoing invasive imaging studies, the authors recommend that if available, OCT or IVUS imaging be performed in patients with MINOCA and evidence of non-obstructive coronary atherosclerosis and angiogram. OCT has a better resolution and is preferable modality. The fourth universal definition of MI, it says additional coronary imaging and functional testing methods may be useful to elucidate the mechanism of ischemia in MINOCA. And the ESC position paper said the same thing. Now, the problem is this is all statement with a recommendation. However, until further research studies are available, use clinical judgment. If you're wondering who's that, this is Dr. Rob. This is another case, 20-year-old male with no past medical history, presented with chest pain. Now, if you look, you can see there is a mobile kind of thrombi that hang in there in the proximal segment of the LID. And you say, it's like, okay, what I'm going to do about it? Should I just treat it? Should I try do thrombectomy, stent that segment? Should I do more comprehensive imaging, intracoronary imaging? And sure enough, you can see there is a very significant big thrombus in there. And I will talk a little bit when we talk about this specific case, when we talk a little bit about the treatment in these patients. How about MRI? Can be routine in MINOCA. And again, there is no really clear cut of should we do it or not. And I don't even know if really it's going to kind of like the cost benefit. I mean, the MRI is not a cheap study, and I'm not sure even whether the insurance is going to cover it or not. But in the statements, the AHA, they say it's a key investigation in MINOCA. ESC, they say it's the key diagnostic tool to be employed in MINOCA patients. And then the fourth universal definition of in MI, they say cardiac MRI can help to diagnose the alternate and rule out alternate conditions. And this is a study that they looked at all MINOCA patients using cardiac MR. And actually, a quarter of them, it's helpful to diagnose a myocardial infarction, meaning a plaque rupture. It can be diagnosed for myocarditis in 33%, Takotsubo cardiomyopathy in 18%, hypertrophic cardiomyopathy in 3%, dilated cardiomyopathy in 2%. And then here is about 26%. We don't know really what's causing their MINOCA. So it's a good tool maybe to rule out other conditions, but it should be really thought about when using it. How frequent do we find infarction on cardiac MR in MINOCA patients? 19% of, in this study of 288 MINOCA patients in a pooled analysis from 3 centers. And they actually saw there's no difference between patients who presented with a STEMI versus an STEMI. They have all the same kind of findings on MRI, not findings, sorry, the frequency of identifying infarction in these patients. If MINOCA is truly MI, how can there be no infarction on cardiac MR? And it's really hard to kind of know. And maybe it's related to the spatial resolution of the infarcted myocyte. Maybe there is a couple myocytes in that area that they have they are dying, and then the other myocytes in the different. And overall, the spatial resolution kind of like sometimes be misleading in identifying the areas of the acute infarction. However, as I said, it is helpful to rule out other differential diagnosis. And it can guide therapy in MINOCA patients. Non-ischemic late gadolinium enhancement or edema not confined to a coronary territory is about 33% of patients who had MRI. And that can cause myocarditis, so conservative therapy can be really helpful in these patients. Infarction or edema in a single coronary artery, you can go ahead and then start them on antiplatelet, statin, if you think about spasm calcium channel blocker. And the majority, they are normal and clear cause. So then you will think about, like, maybe I should do more studying, whether to send them again to coronary angiogram, do intracoronary imaging. And I think this is the part where it's got a little bit tricky in patients with MINOCA. How MINOCA can be treated? The best treatment for MINOCA is unknown because there have no prospective trials in these populations. This is from the ACTION registry that included about 18,900 MINOCA patients. And when they looked at the discharge medications for patients with MINOCA versus patients with myocardial infarction with no obstructive coronary disease, they tend to be discharged on aspirin. The dual antiplatelets, of course, it's more in patients with obstructive coronary disease compared to patients with MINOCA. Statin therapy, it's a comparable. ACE inhibitors, beta blocker. But the problem is what we're treating, really. Can we just, all the patients with MINOCA, just put them on this regimen, and discharge them? We really don't know. Therefore, the optimal treatment after MINOCA is likely to differ substantially by mechanism. Incomplete understanding of mechanism in patients with MINOCA leads to variable use of secondary prevention measures by clinicians. And it's pretty much uncertain about which post-MI treatment guideline recommendation should apply. However, there is two different approaches. Probably is find the underlying cause and treat it, but can the underlying cause always be found? What diagnostic strategy worked the best? Treat as usual MI? Maybe. But are usual coronary prevention medication effective on MINOCA patients? Specifically when I said earlier that the plaque looks a little bit different from patients with obstructive coronary disease. So back to the case of this young man, a 20-year-old male with no history, presented with chest pain while playing soccer. And we established that he does have a thrombus that's hanging there in the proximal LAD. Now this patient, he was treated with tirofiban IV for 72 hours and was discharged on triple anti-thrombotic therapy, anticoagulation, aspirin, and Plavix. And then during the follow-up, this is his angiogram during follow-up, it shows a complete resolution of the thrombus. This is a confirmation with IVUS, there's no thrombus. Now, did we do the right thing? It's unusual to put tirofiban and for 72 hours, give them a month of anticoagulation. So we really didn't know that's true, but definitely patient did well. Another case of 68-year-old male with no past medical history, flu symptoms for 2 weeks, had fitness training and low functional capacity, chest pain that was progressed. Mild dizziness, mild chest pain at night. A point of care troponin was mildly elevated of 1.2. And here you can see there's a little bit of atherosclerosis, non-obstructive. This is the RCA. You underwent OCT of the proximal LAD, and it shows there is a plaque with a little bit of rupture on the OCT. In this case, how would you treat it now? Can you just discharge the patients on just dual antiplatelet therapy or just aspirin and statin? This patient he had a stent. And again, there's no kind of clear answer whether to put a stent or just leave it as it is. And then again, he did better. Eventually, he did an MRI that confirmed the presence of septal myocardial infarction. So overall, the treatment for myocarditis, as I said, is supportive. Coronary microvascular dysfunction. Is a beta blocker helpful? Is ACE and statin? Maybe there's small studies that showed that it's beneficial in these patients. Takotsubo is ACE inhibitor plus we don't know what other medication that can help preventing recurrence. Plaque, probably antiplatelet and statin are helpful, and this is the data more from the obstructive coronary disease patients. Vasospasm, calcium channel blockers and nitrates seems to be helpful in these patients. Dissection, beta blocker, maybe antiplatelets, hopefully can help the patient. Statin, there's a lot of evidence that to avoid statins in SCAT patients. And also for thromboembolism, probably to treat the etiology is the best approach. Anticoagulation, we don't know really if it's helpful or not. So I think including MINOCA in the statements and recommendation is round one, and it can look nice. However, sometimes facts can change in round two, as the result can be sexier and more hotter when supplemented by results from actual clinical trials rather than just recommendation and statements. More research is needed, especially mechanistic studies to date have been small and single centers. We need to define prevalence and outcomes of specific etiologies. Understanding the role of thrombosis, determine the best diagnostic strategy, and try to identify the best target population for further studies. This is an ongoing study, the MINOCA BAT. I'm going to go over it very quickly. It's a 2x2 factorial randomized open-label multicenter trial in MINOCA patients with the ejection fraction more than 40%. Randomized to beta blocker versus no beta blocker and ACE inhibitors versus no ACE inhibitors. And the primary outcome that they're going to look at is death, MI, stroke, and heart failure. And this is all based on preliminary observational data from Sweetheart, which is the biggest so far registry, suggesting that ACE or ARB may be associated with the improved outcome. It's going to be a global collaboration led in Sweden, and there's about 2,100 patients in the US and Canada to be enrolled. What's happening at Emory? I think I'm glad Pooja is here. I'm not sure HARP is still enrolling. So HARP is one of the studies that including women with no obstructive coronary disease. So if you have a patient, they have open arteries with elevation in troponin. These patients, they get a free MRI that covered by the study, and also an OCT that's also covered by the study. And they looked at the three vessels, and it's kind of like identify what's the etiology. So if you have a patient, contact Pooja for these. We have now, it's just accepted for the rational design. We're doing a DIMISTIFY study, and I'm going to try to, it's a little bit, it's the quantification of myocardial blood flow using dynamic PET CTA fused imagery to determine physiological significance of specific coronary lesion. So if you have a patient with the troponin leak, maybe there's an evidence on PET scan of perfusion defect, you can enroll in this study, and then we take them in the Cath lab, we do the regular angiogram, and then also we do more comprehensive physiological assessment, including FFR, IFR, IMR, and then we compare it to the non-invasive way. And we're trying to replicate what we're getting in the Cath lab. The group, Dr. Ernest Garcia is the PI, and Dr. Marina Piccinelli, trying to create a software that actually can do fusion imaging from the CT scan and also from the dynamic PET, and compare it to the findings of the what we're getting in the Cath lab. And also there's a collaboration with the heart flow to obtain the FFR for each coronary vessel. This is kind of like just, it's one of the figures that we include in the manuscript. It's basically we retrieve the coronary anatomy from the CT, fuse it with the PET, creating a 3D image fusion. And then actually we can give you the myocardial blood flow for each territory and also the perfusion for each territory rather than a phantom perfusion imaging that it's now what we are using. Another thing is the iSCAD registry. If you have a patient with a SCAD, it's, you can contact Dr. Wells. It's a collaboration for different institutions. And also, if you are interested in that field to publish, maybe to contact Dr. Wells, he might have access to the data to get something published from him. The MINOCA, the take-home message, MINOCA is a heterogeneous syndrome caused by different pathophysiological mechanisms. Identification of the underlying causes in each individual patient is crucial to determine the appropriate therapy. Patients with MINOCA should receive the same clinical attention as patients with acute myocardial infarction with obstructive coronary disease. I would like to thank Dr. Jabber. He's been a great mentor. Dr. Samedi is a great mentor in the Cath lab. Dr. Pujameta, who brought me here to Emory. My great mentor at Cedars-Sinai, I'm still working with her on a lot of projects. Of course, Dr. Williams has been a great support for this program. The Cath lab team, and then, of course, the cardiology fellows. I couldn't find anywhere where to put this picture, so I thought maybe in the thank you slide. Happy to take any questions. It's good. That's a good sign. No questions.
So, Ahmed, why do you think that, I think the majority of patients who undergo cath and we can't find obstructions, we don't typically in the first admission do OCT, IVUS, provocative testing for spasm. Why do you think that is? Because it leaves, it causes an issue with regards to how people think about the patient, the documentation. It's like an incomplete workup, essentially. Right. Do you think it's because that's just the culture, we don't do it? Do you think it's because it's a workflow issue? You know, do you think we're?
I think this is a great
extra
issue.
Stuff to get paid for the studies.
Yeah.
I mean, from what is the reason that we're not?
That is really this is really an important kind of point. So I'm going to be honest with you. This all MINOCA, and even there's the ischemia with no obstructive coronary disease, INOCA. It's all came in from a lot of initially started in Europe. And Europe, they have all these statements. They're more kind of powered to spend a little bit more time in the cath lab with the patient, do more comprehensive studies for the patients. I agree with you. Sometimes is the fear of the cost benefit for the patient. I mean, you're putting a wire in the patient's coronary. You think that they have open arteries. Are you going to risk it putting an OCT wire, trying to investigate? And sometimes maybe you're picking the wrong coronary artery. So you have sometimes to do for the 3 vessels or the 2 vessels up until you see there is a small plaque rupture or there is some other mechanism. Again, if you cannot find this, they have to jump in and do, for example, a spasm testing. That's include to give vasoactive medications. We've seen it. I've seen patients that arrest just because of giving a high dose of acetylcholine and they spasm. It's in a monitor setting, but still, it's a risky procedure. So I think not having a clear clinical data that shows like, yes, you will get benefit of these things, I think it depends on the culture. It's a cultural issue whether to do it or not. I know that some operators here, they tend to be a little bit more aggressive and try to get to the bottom of it. Some of the operators, they say like, no, I don't think it's going to change the management, which could be true sometimes. However, sometimes it's not. You know, we see these patients come into the emergency room so often with the same thing.
Part of the impetus for my question is, you know, we adjudicate all of these cases with presumptive MI and they have normal coronary arteries. That leads to a whole host of interesting documented diagnoses in the chart, both by cardiology and non-cardiology services, and it's kind of a bear to tease out when we don't have a standard for how to, in the cath lab, work through these patients who initially have non-obstructive coronary disease.
Correct.
I'll make a comment just on a national scene. AHA, the authors of that statement, they, toward the end of their document, state, you know, they are trying to advocate to have like an ICD-10 code
right.
for MINOCA.
Right.
There is another coding group within ACC, which I participate in, where we're reticent to endorse that because oftentimes, you know, right now the coding structure supports types of MI.
Right.
Type 1 MI, type 2 MI, other MI types. MINOCA can fall in any one of those.
That is correct.
And it's sort of a mix of a clinical and an anatomic diagnosis.
Right.
It's not a etiologic or functional diagnosis.
Correct.
And so it leads to attention between, the term MINOCA
Sure.
and the MI types. The MI types are supported by documentation structure. The term MINOCA is not. And there's a concern that if you just put MINOCA, and primarily the reason to have it there is to justify getting paid,
Right.
that you at least Cath the patient, and you came up with an unclear diagnosis. I'm not sure that's a good enough reason to
Correct.
justify having an ICD-10 code
True.
for MINOCA,
Yeah.
because it can potentially prompt people to not do a complete workup. You're satisfied
That is
with
correct.
MINOCA, you don't do the spasm testing, you don't, do OCT.
Mhm.
So it's, just, there's no, I guess all I'm saying is I'm just pointing out that there, even at a national level among AHA and ACC, there's disagreement. If anyone documents MINOCA in a chart here at Emory, it'll likely lead to a query for right or for wrong, just
Right.
because we don't have a way to put MINOCA into the
Which
standard
could.
coding structure, and it's an issue.
Right.
And I think the final summary point is it's difficult for us as an institution to deal with this when we don't have a standard among operators when to be aggressive, when not to be aggressive.
No, I agree with you. I
Those are
totally
my
agree.
Observations and comments.
And I mean, the reason I'm doing all, and again, it's a little bit of confusing whether to do it and do more comprehensive studies or not to do anything. Nobody really knows. And that's kind of like, I'm interested to kind of like look at that just in terms of, because there's a lot of talk about it. There's a lot of sometimes even confusion about it. The European always in every conference, they have a big session about it. I think the ACC in the past year or so, they start to kind of pay more attention and they have a full session. But yeah, I mean, I think there's a lot of issues with MINOCA.
My predictions on trials would be
Could be, yeah.
5,000
Mm-hmm. Yeah.
Such a heterogeneous bucket.
Yeah,
Applying gene treatment to such a heterogeneous bucket.
I agree. Yeah. Thank you.
The preceding program is copyrighted by Emory University.